Our lecture today is about glaucoma. Glaucoma is a disease in which the pressure inside the eye is sufficiently elevated, resulting in optic nerve damage and visual field loss. So we have a triad of increased intraocular pressure, optic neuropathy, and visual field changes. If glaucoma left untreated, it will cause irreversible loss of vision. The normal intraocular pressure lies between 10 and 22 millimeter mercury. One type of glaucoma is primary open-angle glaucoma. It is a bilateral genetically determined elevation of intraocular pressure, incompatible with health and function of the optic nerve fibers, which will result in progressive field changes, optic cupping, and visual loss, and associated with an open angle of the anterior chamber. According to the angle of the anterior chamber, we have two types of glaucoma. Open angle glaucoma, in which the angle of the anterior chamber is open, and angle closure glaucoma, in which the angle is closed. Each of them can be either primary or secondary to an etiology, either in the eye or systemic condition. In the primary open angle glaucoma, it is usually a bilateral condition and has a genetic predisposition. The intraocular pressure will rise enough to cause changes in the optic nerve fibers, which will lead to optic neuropathy and progressive loss of the visual field. Many criteria would cause a glaucoma suspect and would increase the risk factors for this person to develop primary open-angle glaucoma, like strong family history of glaucoma, age of 45 years or more than that, dark race, myopia, vasospastic disorders as migraine and Raynaud's disease, and ocular hypertension. Diagnosis of primary open-angle glaucoma is usually late and difficult, as the patient usually complains in late stages of the disease, because many cases are asymptomatic and accidentally discovered with routine examination and intraocular pressure measurement. That is why routine checking of intraocular pressure of any person above the age of 40 is the only way to discover the disease before it steals vision. The signs of open-angle glaucoma: 3 cardinal signs: elevated intraocular pressure, cupping of the optic disc, and visual field changes. Elevated intraocular pressure is a major risk factor for development of glaucoma. Usually, the intraocular pressure is elevated in all cases of glaucoma, except in cases with normal tension glaucoma, where optic neuropathy characteristic of glaucoma and characteristic glaucomatous optic field changes occur with normal intraocular pressure. The second important sign is optic nerve changes. The most important structure to be examined in glaucoma is the optic nerve head. The normal cup-to-disc ratio is usually 0.3. This is changed in glaucoma. Usually, large disc cup more than 0.4. The cup is deep. Increased visibility of the pores of the lamina cribrosa through the cup is characteristic of glaucoma. Retinal nerve fiber layer defects are seen with green filter, and more accurately assessed with OCT. Nasal shift of the vessels will occur in a glaucomatous cup. Visual field changes characteristic of glaucoma. The most crowded fibers of the optic nerve are the temporal fibers above and below the macula, which are called the arcuate fibers. And this explains why the earliest glaucomatous field defects occur in this zone. The least crowded fibers are the macular fibers, and this explains the relative sparing of the visual acuity until late stages of the disease. That is why this disease is generally asymptomatic, as the central vision is preserved until very late stages of the disease. Assessment of the visual field with kinetic perimetry, we may find the paracentral scotoma. The earliest clinically significant defect is an isolated scotoma. Scotoma means a blind area. As the disease progresses, the scotoma elongates circumferentially along the distribution of the arcuate fibers to connect with the blind spot. So, the scotoma connecting to the blind spot will form either upper or lower arcuate scotoma. When both upper and lower arcuate scotomas are present, they form central ring scotoma. In advanced cases, peripheral concentric contraction of the field occurs and fuses with the central defects until only a small island of central vision is preserved. And this is called a tubular vision or tunnel vision. With the static perimetry, the defect of the visual field, which is the mean sensitivity, is localized to a particular retinal area. Optical coherence tomography is used to detect early loss in the nerve fiber layer. It helps in early diagnosis and follow-up of glaucoma before the development of pathological cupping or detectable field changes. So it is an early and sensitive diagnostic modality of early cases of glaucoma before the development of late field changes and tunnel vision. Management of primary open-angle glaucoma is mainly medical, but in certain conditions, we may need to shift for laser treatment or surgery. These conditions include progressive nerve fiber layer damage, progressive optic disc cupping, and/or progressive field defects, though we use maximum tolerated medical treatment. In a patient who is non-compliant to medication, this will lead to wide fluctuations of intraocular pressure that may lead to progress of optic cupping and field loss, and a more stable option is needed. Intolerability to medical treatment or significant side effects of the drugs. Medical treatment includes topical eye drops like beta blockers. This group of medications will decrease aqueous formation. An example of these medications is timolol, which is a non-selective beta blocker, and pitaxolol, which is a selective beta blocker. Side effects include systemic side effects can be quite dangerous, as worsening of bronchial asthma and heart disease, worsening of cardiac conditions. Adrenergic agonists, as epinephrine and brimonidine, they act by increasing aqueous outflow. Myotics or parasympathomimetics, myotics as pilocarpine with concentrations of 1 to 4%, leading to contraction of the ciliary muscle, which will pull on the trabecular meshwork, thus increasing the aqueous outflow. Side effects of myotics include ocular side effect as constriction of the field of vision as we narrowed the pupil, will decrease the light rays entering into the eye. Worsening of vision in patients with cataract, spasm of accommodation, development of cataract. Excessive use may cause pupillary block glaucoma. Systemic side effects include bradycardia. The fourth option of medical treatment is prostaglandin analogs. They reduce intraocular pressure by increasing the aqueous outflow. Carbonic anhydrase inhibitors can be topical as dorzolamide, which will decrease aqueous humor formation. Systemic carbonic anhydrase inhibitors are also available. These are very effective medications but have a lot of systemic side effects on the GIT, urinary, and nervous systems. That is why they are used only for a short-term treatment as in secondary glaucoma and postoperative cases. The most common drug is acetazolamide. Laser trabeculoplasty. It is the technique of applying laser burns, which is argon laser, to the trabecular meshwork, aiming at shrinkage of the trabecular ring, leading to widening of the intertrabecular spaces. This will lead to increased aqueous outflow. Surgery. The standard technique is subscleral trabeculectomy. Surgery reduces the intraocular pressure by creating a channel for the exit of aqueous humor from the antechamber into the subconjunctival space. Resistant cases may need a glaucoma device, which is a large reservoir implanted on the sclera between the two rectus muscles and connected to the anterior chamber with a silicon tube, as this case Ahmad glaucoma valve. Ciliary body ablation procedures is also a surgical option. The principle is to destroy part of the ciliary processes which are responsible for aqueous production, and thus we are decreasing the aqueous secretion. It's indicated in difficult cases and cases unresponsive to other measures. These cycloablative procedures include cyclodiathermy, cyclocryotherapy, cyclophotocoagulation, which can be transscleral or transpupillary. Ocular hypertension. Ocular hypertension is an elevated intraocular pressure without evidence of anatomic or functional damage to the eye. The optic disc cup is normal in size, and the field of vision of the patient is normal. So we need to follow up to exclude the possibility of transformation into glaucoma. So in ocular hypertension, though there is increased intraocular pressure, the optic nerve and field are still normal, and follow-up is mandatory to watch for fear of development of glaucoma. Normal tension glaucoma. In normal tension glaucoma, the intraocular pressure is not high, though the optic disc cup and field of vision are affected. In those patients, the intraocular pressure should be kept below 12 mm mercury. Open-angle glaucoma can also be secondary to conditions in the eye or systemic conditions. Can be lens-induced glaucoma, like phacolytic glaucoma. It occurs in hypermature cataract. Treatment is by lens extraction. Phacoanaphylactic glaucoma, it follows trauma or surgery, where the lens proteins are released into the ocular fluid and initiate an autoimmune reaction, the products of which are deposited on the trabecular pores, causing their narrowing. Glaucoma can also occur secondary to intraocular inflammation as uveitis. The cause of glaucoma is the plasmoid aqueous. Treatment is management of uveitis as usual, with atropine and steroids. Treatment of glaucoma by beta blockers and local and systemic carbonic anhydrase inhibitors. The use of prostaglandin analogs in these cases and miotics should be avoided as possible. Traumatic glaucoma. Open-angle glaucoma following trauma may be due to traumatic iridocyclitis by the same mechanism as occurring with uveitis. Hyphema. The blood in the anterior chamber may directly obstruct the pores of the trabecular meshwork. Ghost cell glaucoma. It occurs in long-standing cases of vitreous hemorrhage, where the red blood cells break down and the rigid walls of these cells, which are called the ghost cells, diffuse into the aqueous and obstruct the trabecular pores. Angle recession glaucoma. Glaucoma following trauma secondary to tear in the ciliary body and recession of the angle structures backwards that may obstruct the aqueous outflow channels. Glaucoma secondary to intraocular tumors. In choroidal melanoma and retinoblastoma, the intraocular pressure may rise due to the associated intraocular inflammation, obstruction of the episcleral veins by the growing tumor. So here, the tumor will directly invade these veins and causes increased episcleral venous pressure. Obstruction of the trabecular pores by the malignant cells. Corticosteroid-induced glaucoma. Secondary open-angle glaucoma may follow the prolonged use of corticosteroids. This is managed by stopping the steroid therapy, but if steroids are absolutely necessary and cannot be stopped, we can add topical beta blockers to lower the intraocular pressure. Thank you. We are now viewing some photos of atlas of glaucoma. This is a case of facial hemangioma and Sturge-Weber syndrome. This is associated with glaucoma as these conditions usually elevate the episcleral venous pressure. As you can see in this photo, there is new rubeosis iridis or new vessels at the iris. This can cause neovascular glaucoma. This condition can occur with long-standing proliferative diabetic retinopathy, and ischemic vein occlusions and ocular ischemic syndromes. Can also be associated with chronic retinal detachment. This is another photo of rubeosis iridis evident, as you can see at the iris. This is a case of glaucoma secondary to chronic iridocyclitis. You can see signs of chronicity as the posterior synechiae and the appearance of stoned pupil. You can see the keratotic precipitates at the cornea. This is a picture of normal non-glaucomatous optic cup. As you can see, the cup disc ratio is less than 0.3 and the vessels rise from the center of the cup. This is a case of early glaucomatous cupping. You can see enlargement of the cup and starting nasal shifting of the blood vessels. There is here moderate cupping, there is increased cupping, nasal shifting of the blood vessels, and more evident foramina of the lamina cribrosa. This is a case of advanced glaucomatous cupping. You can see the large cup, nasal shifting of the blood vessels, and myonetting of the blood vessels at the margins of the cup. Here you can see a patient undergoing automated perimetry to test for visual field and retinal sensitivity. This is a handheld Perkins tonometer through which the doctor can assess the intraocular pressure. This is a gonioscopic appearance of wide open angle. Gonioscopy means visualization of the angle of the anterior chamber. This can be done by the use of gonio lens and gonio prism. The gonio lens is a lens by which the doctor can examine the angle using the lens and with the help of a slit lamp examination. This is a gonioscopy with Goldman lens. You can see it is a contact lens and topical anesthetic should be applied before the use of the lens, and a coupling agent is put between the lens and the cornea. So, what is the treatment of choice for primary open-angle glaucoma? As we said earlier, it is medical treatment. And in certain conditions, we may need further treatment with laser and surgery. But we first of choice is medical treatment. You have been referred a case of open-angle glaucoma. Which of the following would be an important point in diagnosing the case? Is it a shallow antechamber? No, this is true for angle closure glaucoma. Is that optic disc cupping? Yes. Optic disc cupping and characteristic visual field changes are characteristic of the cases of open angle glaucoma. Is it a narrow angle? No, we said it is an open angle. Visual acuity? No, as we said earlier that the central vision is preserved until very late stages of the disease. So the visual acuity may be normal until late stages of the disease. Refractive error? No, as refractive error such as myopia is just a risk factor for development of open-angle glaucoma, and it doesn't diagnose or directly lead to, it's just a predisposing factor. So the answer of this question is optic disc cupping. Thank you.